I see our attendees coming in, so we will just give it a few seconds more. My name is Julia Ju, and I welcome you all to the Indo-Africa Vaccine Summit. NatHealth and Africa Healthcare Federation have come together to hold a vaccine summit that seeks to address some of the critical factors that constrain Africa's ability to achieve desired COVID vaccination levels, and what can be learned and replicated from India's model. Both Africa Healthcare Federation and NatHealth have got the industry support behind this to make national vaccine programs successful. The Indo-Africa Vaccine Summit has brought key national and international stakeholders and leaders together who will discuss and present short-term and long-term focus areas related to COVID vaccination. The summit is designed to offer insights to address the vaccine access, hesitancy, infrastructure, and supply chain challenges to ensure equitable access to vaccines in the African countries. Before we start, I would like to make housekeeping announcement. For our audience, please use the Q&A function on the bar at the bottom of your screen to type in your questions. The moderator will be able to see and address them. Please do mention whom your question is addressed to. Now, for the welcome address, I would like to invite on screen Dr. Harsh Mahajan, President, NatHealth, and founder and chief radiologist of Mahajan Imaging. Dr. Amit, I would request you to please come on screen for the welcome address.
Thank you so much, Julia. And I hope that we can get Dr. Harsh Mahajan's recording being shared soon. Let me first thank NatHealth India as the Healthcare Federation. You have shown how togetherness with public and private sector can achieve great results. Many of the champions are on the call with us. I'm also delighted from Africa. We've been able to bring leaders from Ethiopia, Kenya, and beyond, not only on the panel, but also participants today to share some of the success stories that we shocked the world. To be honest, Africa did shock the world about how we managed COVID in the first few months, but it wasn't easy. There was no vaccine, and yet we needed to keep the infections down. You will hear from leaders what they did, but now we have another challenge. And that challenge is to have more people vaccinated in a short time. So beyond the access, now it's about the last mile and reach. So like the Samrid project in USA that picked up so many interesting innovations in India, we have already started working with a few companies like AWL, Plus, Black Frog, to start showing what works in some countries can also work on the continent. And vice versa, some of our strategies could be adopted by the champions in India to reach the remote places as required. You know, the friendship we have is really long-standing. And I'm sure that the Commissioner, High Commissioner of India to Kenya is going to talk about the friendship a lot. Mine is to welcome. I've been really enjoying working with Dr. Harsh Mahajan and Siddhartha Bhattacharya and the entire leadership of the NatHealth India. This panel is the first step to many more interventions and engagements. So it begins with a dialogue. This is our second summit, and we are just looking forward to building our friendship. So on behalf of Africa Healthcare Federation and the board and the directors, as the president of Africa Healthcare Federation, I welcome you all on this second Indo-Africa Vaccine Summit. Over to you, Julia.
Thank you so much, Dr. Thakkar. It's always a pleasure to listen to you. Now we have a short welcome message from Dr. Harsh Mahajan, who is the president of Nat Health. I would please request you to play the video.
Dr. Leah Tadesse, Honorable Minister of Health, Ethiopia. Dr. Arish Sharma, CEO, National Health Authority, Government of India, and former Secretary, Government of India. His Excellency, Dr. Virinder Paul, High Commissioner of India to Kenya. Mr. C.K. Mishra, former Union Secretary, Government of India, Ministry of Health and Family Welfare, and Ministry of Environment, Forest and Climate Change, Director IP Global Limited and Senior Advisor, Serum Institute, India. Ms. Anjali Kaur, Deputy Assistant Administrator, USAID. Dr. Amit N. Thakkar, my dear friend and President, Africa Healthcare Federation. Friends from the industry, media, ladies and gentlemen. I'm happy to join you all at this second edition of Nat Health and AHF Partnership, organizing the Indo-Africa Vaccine Summit 2022. I welcome you all to this summit. Nat Health lauds the efforts and outcomes which the first summit had generated in 2020, where the deliberations revolved around the need for strengthening healthcare in India and Africa, with an objective to not only come up with suitable, sustainable solutions that would help make universal health coverage a reality, but also catalyze sector transformation through effective partnerships. The potential areas of collaboration in healthcare that emerged were sustainable medical value travel, skill transfer and training, infrastructure development for hospitals and diagnostics, and manufacturing, research, and artificial intelligence. With the ongoing COVID-19 pandemic, several countries across the world are accelerating vaccination to eligible population to safeguard them. With an objective to strengthen the vaccination drive in Africa and share best practices, we have all gathered here today virtually. According to the WHO, more than 50 countries missed the target to fully vaccinated 10% of their populations against COVID-19 by the end of September 2021. Africa is amongst the most impacted. Vaccines are the most critical tool to end the pandemic and to save both lives and livelihoods. Despite having a huge population spread across diverse geographies that leads to logistical challenges, India has proven its capability by delivering over 1.7 billion doses and even setting a record of 25 million plus doses in a single day. And over 75% of its adult population is fully vaccinated. We are certain that the summit will regain the required focus on ramping up vaccination drives across nations amidst learning from each other. Over the course of today's deliberations, the summit will address and highlight the India story by looking into insights to the access of the vaccine, infrastructure and supply chain challenges for equitable distribution and injection of vaccines. I look forward to an engaging discussion and key meaningful outcomes in partnership between the two continents in the really true spirit of South-South cooperation. Thank you and all the very best.
Thank you so much, Dr. Mahajan, for sharing your perspectives and for that warm welcome. As a special guest, we have with us His Excellency, Dr. Virinder Paul, High Commissioner of India to Kenya and PR to UN Environment Program and UN Habitat. I would request you, sir, to please come on screen and address our attendees.
Thank you. I hope you can see me on the screen.
Yes, we can.
Namaskar, Jumbo. Good afternoon, everyone. I bring you all greetings from the Indian High Commission in Nairobi. It's my pleasure to be with this India-Africa Vaccine Summit being co-hosted by Nat Health of India and Africa Healthcare Federation to examine certain key factors constraining Africa's ability to achieve the desired COVID vaccination levels and what could possibly be done, gaining from India's model and India's experience. Chairman Dr. Amit Thakkar, Dr. Harsh Mahajan, thank you so much for asking me to join such an impressive gathering of distinguished experts and leaders representing practically all areas of action. It is this action that determines the course and outcomes of what we discussed today. I would like to recognize with admiration the presence of all the senior experts and officials who are present in this virtual room from India, from Kenya, and also from other African countries. In this, what I would like to describe as a well-timed, reflective dialogue. We are touching upon a range of topics: management of vaccination campaigns, policy making, technology, innovation, advocacy, resources, finance, vaccine development and manufacturing, supply chain challenges, vaccine access, vaccine hesitancy, vaccine equity, vaccine nationalism, vaccine internationalism, etc., etc., etc. And this wide range of themes makes this meeting ever more important. It's extremely satisfying for me as the Indian High Commissioner to see the African Health Federation and the Indian Health Federation joining hands, bringing together some prominent people who are dealing with their own hands, as they say, the challenge of the COVID-19 pandemic. How is the virus going to behave in the coming weeks and months? Where is this pandemic headed? How much more the world must suffer this agony? These are some of the questions that we hear every day. At the same time, we also hear from experts that the acute phase of the pandemic that was associated with large-scale deaths and hospitalizations might be ending this year. The virus itself is very unlikely to go away completely and will probably settle down into a pattern of transmission at low level, causing occasional outbreaks in under-vaccinated population. We hope that that is the end game here, but we are certainly not there yet. This is going to be a bumpy road on the way to low levels of COVID. The shared goal internationally is therefore to raise the level of preparedness to effectively deal with this challenge and also future threats of emerging and re-emerging infectious disease. I'm very glad to see in the program that many of these points would be discussed in much greater depth in various thematic presentations that will come up in a short while. The topic given to me is rather general. It is setting the stage for India-Africa collaboration in healthcare. In fact, a lot has been done already to build a successful tradition of healthcare collaboration between India and Africa. In other words, the stage has already been set. But what I seek to do in a few minutes that I have is to broadly recall where we come from and where we are headed together. Healthcare cooperation is embedded in our larger Africa policy, in which development cooperation, capacity building, training, education, healthcare, and all of that we jointly agree to do is aimed at Africa's sustained socioeconomic development. This is conducted largely in the South-South format. It's about shared goals and aspirations and India's declared commitment to share our capacities and strengths with Africa. This approach has been, since India's independence, the foundation of the ties of friendship and partnership between India and Africa. This is driven by deep mutual understanding at the highest political levels and also sustained by the goodwill for each other at the people-to-people level as well. I'm proud to say that relations with Africa constitutes a major direction of India's overall foreign policy. In this backdrop, practical cooperation with individual countries is aligned with the actual needs that need to be addressed in the mode of collaboration. India wants to be a steady partner in Africa's consistent growth and development towards higher levels of socioeconomic development. Now, coming to some specifics on the healthcare side. In the India-Kenya context, in recent years, one of the visible symbols of our cooperation is a state-of-the-art machine from India called Bhavatron, which has been treating cancer patients every day at Kenyatta National Hospital in Nairobi since 2017. It has considerably improved cancer treatment outcomes in Kenya. Another visible aspect is what is commonly known as medical tourism. What's the answer when our Kenyan friends look for world-class medical treatment by world-class doctors at cost that is fraction of what they would pay in the developed world? What's the answer? The answer is your search ends here. Look no further. India is the solution. India has been, as most of us living in Africa know, India has been a preferred destination for quality medical treatment. On similar lines, there are understandable expectations in Africa that India should be equally forthcoming in COVID-like situations as well. And this is what India has done since the onset of the pandemic. When supply chains are disrupted and demand outstrips supply, the most vulnerable will inevitably get hit the hardest. Even during the worst period of the pandemic that we have so far seen, India kept almost all its supply lines open, ensuring that critical medical equipment, medicines, and other supplies could reach the countries in need. India's reliability as a partner in these difficult times has been recognized around the world. Early last year, under India's Vaccine Maitri initiative, Vaccine Maitri is an expression in Hindi that means vaccine friendship. Kenya received 100,000 doses of Covishield from India. Covishield is the name given to Made in India Oxford AstraZeneca. Separately, Kenya also received a little over 1 million doses of Covishield under the COVAX group. And all that stock helped Kenya initiate their COVID vaccination drive. We are happy that India has played a role in that process. In the early months of the pandemic, India had also supplied a consignment of medicines to treat COVID. A good number of Kenyan healthcare professionals and administrators have also benefited from online e-tech courses on COVID-19 organized by Government of India. As part of our specialized digital infrastructure, India has developed and extensively used COVID. Now, COVID, which stands for COVID Vaccine Intelligence Network, is an online platform for the management of large-scale vaccination programs. India has offered COVID free of cost to all countries globally. Indian and Kenyan experts have already discussed and exchanged notes on various technical nuances of the COVID vaccination platform, and I'm very happy that there is a standalone session dedicated to COVID that's going to come up as we go along this afternoon. Most recently, we have agreed on mutual recognition of COVID vaccination certificates issued by India and Kenya. We are also working to formalize an agreement, a bilateral agreement in the health sector to further structure and consolidate our collaboration. We are also looking at a greater use of traditional systems of medicine in both our countries. We have noted Kenya's plans and remarkable efforts to be self-reliant in vaccines, biological products, and pharmaceuticals through setting up manufacturing facilities. In Kenya, India stands more than ready to join hands with Kenya to discuss new such areas using our rich past experience of working together on mutually helping basis. India's private sector is also keen to build more institution-to-institution linkages in healthcare, which we would encourage. Global preparedness is the key to dealing with the global challenges of today and tomorrow. It's not just the issue of vaccines alone that we are discussing today. It's about other things as well, such as essential drugs, including antiviral drugs, affordable and effective diagnostics and devices and instrumentation that need to be reliably made available in low resource settings in developing countries. We do need low cost solutions driven by appropriate technologies in a genuine spirit of caring and sharing internationally. Before I conclude, let me say, and most experts would already know that in public health situations across the world, at different levels, in different settings, sometimes the last mile proves to be the hardest. And we are constantly learning. We have done so much together, and there is so much more to do. Thank you, and I wish this dialogue every success.
Thank you so much, Dr. Paul, for sharing your thoughts with us. Next, we have our keynote addresses on effective vaccine management. For the same, I would like to invite Mr. Sunil Thakur, Treasurer, Nat Health and Partner, Quadria Capital, to be the facilitator and introduce our guests and the topics.
Thank you, Julia. As part of the next session, more importantly, to share the reflection from the African continent on using technology to scale up vaccination, I would like to invite Dr. Leah Tedase, Honorable Minister of Health, Ethiopia, to share her perspective. Just a brief bio about her illustrious career. She is currently the Minister of Health of the Federal Democratic Republic of Ethiopia since March 2020. Dr. Leah brings in extensive experience as a clinician in the healthcare leadership, academia, and hospital and program management with over 20 years of experience. Prior to joining the Ministry of Health, Dr. Leah served as Program Director at the University of Michigan's Center for International Reproductive Health Training, Michigan, where she has successfully partnered with several institutions in both Ethiopia and Rwanda to increase the quality of reproductive health services and training. Dr. Leah's passion is strengthening and reforming health systems, and she received recognition for her accomplishments and advocacy for gender equity and access to quality healthcare services and training. With that, I would like to hand over the stage to Madam Minister. Over to you.
Thank you. Thank you very much for the kind introduction, Mr. Thakur. Your Excellency, Dr. Virander Paul, High Commissioner of India to Kenya, Dr. Harsh Mahajan, President of Nat Health's Healthcare Federation for India, my colleague and friend, Dr. Amit Thakur, President for the Africa Healthcare Federation, distinguished participants and all protocols observed. First and foremost, I would like to say that I'm really honored to speak at this Indo-Africa Vaccine Summit, which focuses on how to best ensure access to COVID-19 vaccine through transparency and effective vaccine management, particularly with the use of technology. Africa's 54 nations are currently rolling out COVID vaccines, and nearly 392 million doses have been given to beneficiaries in the continent. However, just 3% of almost the 10.3 billion doses given globally have been administered in Africa, and only around 11.6% of Africans are currently fully vaccinated, compared with more than 60% in many high-income countries. And these vaccines in Africa are mainly supplied through COVAX, some through AVAT and bilateral donations. And as was mentioned earlier, with the supply issues currently improving globally, in many countries, the main challenge now has become vaccine delivery. There is great need to support countries to scale up delivery systems and mitigate demand and supply side challenges and reach their global and national vaccination goals. And areas that need support when we look at them are quite a range of them, ranging from community engagement up to the last service delivery. And to achieve this, it's encouraging to see now that global partners like COVAX are now allocating better funds and mobilizing more resources for country-specific supports. And from reviews of rollouts and campaigns in different African countries, lessons and recurrent themes are emerging. And some of the key lessons for successful COVID-19 vaccination campaigns that emerged include strong political leadership, which is foundational, data-driven management, and cross-sectoral collaborations have been some of the recurrent themes that have emerged. We have also witnessed that Africa's experience on previous mass vaccinations has been one of a big plus for this COVID rollout. And as we all know, African countries are used to vaccinating large segments of their populations against different outbreaks and diseases like measles, polio, Ebola, and many countries are drawing on these experiences as well as the existing infrastructure for the current COVID-19 vaccine rollout. And when we look at strong government commitment and engagement, in the beginning, more than 40 countries had finalized their national vaccine deployment plans before their first vaccines arrived in these countries. And typically, it was seen that these countries perform better than those with less developed or no plans. And I want to highlight a few countries' experiences based on a recent article by WHO highlighting interaction reviews that some African countries have done. And to start from my own country, Ethiopia, we have used 80% of the available vaccines we had. This was done around a month ago. And one good practice was using reverse logistics system to bring back vaccine doses from areas where they were underutilized, redistributing them to areas with higher demand, avoiding expiry. In Ghana, good planning helped the country make use of innovative tools such as drones to reach far-flung communities. And few countries are struggling to administer even 50% of available doses, yet many countries are also finding creative ways to drive up demand. And examples of particularly using technology to fight misinformation, we can see Ghana's Misinformation and Rumor Management Task Force that works at national and subnational level to address false claims. Senegal's toll-free call centers provide facts to uncertain members of the public. We can also look at Botswana's arm-ready social media campaign to increase demand. And Ethiopia also uses toll-free lines, we heavily use mainstream media, social media, and work with religious councils and institutions to provide facts and fight misinformation. While we have some encouraging experiences for effective delivery of COVID vaccines, there are glaring challenges identified that we need to address and also use them as opportunities to improve our systems. One key challenge is that COVID vaccine delivery is not fully technology assisted. And obviously, challenges could be better tackled with digital platforms. Technologies are better tools to ease both programmatic and logistical challenges that the rollout is facing. But not only is it limited to this, digital platforms could also guide a tailored and data-driven demand generation, as mistrust and misinformation and disinformation are driving down demand in many African countries. And this requires strong partnership between the private and the public sector. And I want to take the opportunity to really thank the Indo-African Vaccine Summit organizers for the focus of this summit as it's happening in the right time. Our effort to enhance COVID-19 vaccines will only be quickly realized if we really focus on digital solutions. Good data management systems are crucial for mass vaccination campaigns, and also keeping it real-time and relevant requires the right software and systems to be in place. And many countries have tried to go digital during this vaccination process, aiming for real-time data capture and registration to make vaccine experiences smoother. We can particularly using QR codes to verify vaccinated individuals, which we see in Ghana, and we have also starting in Ethiopia. Angola had encouraged its citizens to pre-register for vaccinations to avoid overcrowding at immunization sites. And several countries have made good use of digital platforms to monitor adverse events following immunization, which we also launched in Ethiopia recently. Even though there are many experiences across the region, there is much room for improvement and much room for new technology to enhance Africa's ability to capture data that can inform action in real time. India's experience showcasing from the power of political commitment up to the strong use of IT has really facilitated remarkable achievement. And the practical example that will be seen today of India's COVID Vaccine Intelligence Network COVIN system, a government-owned web portal for COVID vaccination program, is really an excellent lesson, an opportunity that African countries can explore and adopt as we move forward. Given India's geographic size and population, it was really a daunting task to plan the COVID-19 vaccination program, but India's advancement in a digital platform has made it possible. More than 64% of the country's population of nearly 1.4 billion people have received 2 doses, which is really remarkable. The speed of administering these doses has been really impressive, from 100 million to 1 billion just from April to November 2021, which is an average of 3.75 million doses daily. At this juncture, I'd really like to congratulate the government of India and its partners for this impressive progress through this approach. And a big lesson should be drawn in terms of scale up of COVID-19 vaccine rollouts by regional and global partners, not only for effective vaccine delivery, but for also end-to-end transparent system building. So as we go forward, I believe the major issues to consider and focus are technology-assisted mass vaccinations through increased demand generation, and also looking at strengthening and expanding our logistics system, including our cold chain capabilities. And to achieve this, improving engagement of countries to design evidence-based, country-focused sustainable interventions, and supporting regional capacities like the AVAT platform, I believe, are key. So I hope and believe today's summit will discuss in depth on these issues and share valuable experiences that can help us ensure equitable access to vaccine. And I would finally like to sincerely appreciate the Africa Healthcare Federation and NatHealth Healthcare Federation of India for organizing this important and timely summit. Thank you so much.
Thank you, Dr. Leah. Very insightful. And if I can just recap some of those thoughtful suggestions, that you mentioned for the benefit of the audience. So while on one hand you mentioned about the challenge of underpenetrated vaccine rate compared to the rest of the world, and also the supply chain challenges that Africa as a continent has been facing, you've clearly outlined the right critical success factors, starting with the commitment of the political leadership, the cross-sectoral collaboration, and the mass vaccination experience from the prior years that you've brought into to enable the COVID situation, and then more importantly, the experience and the effectiveness with which some of the countries that you mentioned have used things like reverse logistics to sort of rebalance the entire demand and supply using drones. These are some of the experiences that one could use in other geographies, in other countries, because if you've been able to solve using these kind of technologies and processes in a difficult terrain like Africa, it is much easier to solve it in countries like India or other emerging markets. and then the importance of digital tools, solutions, data management to carry out an effective program the way you guys have done it in Africa. Thank you so much for that insightful talk. Now, using that as a segue, I'm bringing the importance of transparent and effective vaccination management through information technology, which becomes key to ensuring vaccine access to all. And therefore, that sort of creates the spotlight for today's discussion. And the focus is going to be on India's COVID system. To talk about the same, I would like to invite Dr. R.S. Sharma, who is the Chief Executive Officer of NHA, Government of India. Just to give a brief, all of us know about his illustrious career, but just to recap, he currently serves as the CEO of NHA, which is under the Ministry of Health, the Government of India, the institute that basically programs and manages PMJAY and Ayushman Bharat Digital Mission, which is ABDM. He also serves as the chairperson of the Empowered Group on Vaccine Administration for COVID-19. He's a 1978 IAS batch pass out, and prior to joining as the CEO of NHA, he was the chairman of Telecom Regulatory Authority of India. He has a distinguished career with the Government of India and state governments, leading reforms and leveraging IT to simplify administrative process. With that, I would request Dr. Sharma to enlighten us with his thoughts around the subject. Sir, over to you. Sir, you are on mute.
Well, thank you very much, Sunil, for that very generous introduction. I was actually in the conference since last about 15-20 minutes, and I was hearing Dr. Leah, and I think I realized how all these issues which she was raising was actually the issues being faced by almost every country. So it resonates with our kind of problems and our kinds of issues. So that's very, very heartening. I would like to thank NetHealth team for inviting me to this Indo-Africa Vaccine Summit. And the topic of vaccination is very close to my heart, because I have been involved in it since last about more than a year now in this venture. And the thought process of that started way back in June of 2020. When actually I made a small presentation to the Prime Minister of India, and wherein I said that yes, vaccines may be a few months away, but vaccinating 1.3 billion people, which is 1/6 of humanity, is not a trivial task. It will require a huge amount of logistics, manpower, infrastructure, information technology, all kinds of things will have to be mobilized. And the scale of the problem is extremely, extremely large. So therefore, it is necessary that unless we create a technology backbone which can ensure an orderly, transparent, regular process of vaccination, and also ensuring the coverage, the inclusion, this is not going to be possible. There will be absolute chaos if we do not have any system. And you can imagine, you are yourself from India, you can imagine the kind of way, if there is an information asymmetry, a lot of rent seeking starts taking place. And I'm sure it happens in every society, not particularly in India. So people will start saying, oh, I know this fellow there, I can manage your vaccination. Oh, I even know this and that. This thing will happen. And if you are vaccinating everybody, this will happen at an order of magnitude larger than what you can probably imagine. So therefore, we came up with a platform, a technology platform, and the Honorable Prime Minister launched the program on 16th of January 2021. And we actually got involved in real development sometime in the month of October, November. So we had a very little time to develop the system. But we did develop a system, and that system, we actually, I must sort of tell you the overarching objective of developing that IT system, where one, it should be very, very inclusive, which means people should find it very easy to get into the system, to register into the system. So we just said you don't need usernames and passwords because nobody is going to remember them. Everybody in this country we have got 1.2 billion mobile phones in this country. We have got 600 million smartphones. We have 800 million plus internet connections. So I said almost everybody has a mobile phone. Just use the mobile phone and OTP to enter into the system. Number one. Number two, it should not only sort of help people in registering into the system. It should also enable people who have not been able to register to go to the site and get themselves vaccinated. And from there, that digital journey will start. And now we have the phone number and the basic detail of a person as to when a person was vaccinated. Thereafter, we should have a system of sending messages to him that your second dose is due now. Then obviously a person will have to figure out as to where I should go, which are the places which are offering me vaccination services. So therefore, there should be a whole list of hospitals, vaccination centers where vaccination is being provided. Then of course, he also has a problem. If I go there to that vaccination center, will I be vaccinated? Will I get a sort of shot or not? Because these guys also have a limited capacity. So basically, we created a system where the entire vaccination vacancies were published real time online. So basically, you could search, and then you could book your vaccination, and then you will be given a time, and then you can go and get yourself vaccinated. So this became a very simple system. Whether a very VVIP was looking at the availability or whether a poor man is looking at the availability, the information asymmetry was just non-existent. There's no information asymmetry. Everybody is looking at the same single source of truth. That's one part. And secondly, we are now having a data of each person, whether the guy has been vaccinated or not, what is the first time he got vaccinated, which vaccine, because India also has a lot of functional illiteracy. So, I might have been given a co-vaccine the first time, and I might, get a Covishield the next time. So we are keeping track to ensure that a person who has been given co-vaccine the first time, he's shown only those centers which are offering co-vaccine and not the other one. And we ensure that he gets the second jab at the time which is decided. So basically, this software was made inclusive, number one. Number two, it was made completely transparent. It was basically made multilingual because, as you know, India is one country, but it has 26 languages and 10, 12 scripts. So we had to ensure that the software or the platform was available in many languages. And it is basically the most important part is you can't provide one app at the front end and so everybody should download the app and put on the app. If you don't have an app, you can go to website. Now, similarly, but we made open architecture. The whole system was made, we published the APIs in the system in the beginning itself. And today you will be surprised to know we have 110 apps which are working as front end of COVID. You have Paytm, you have Max Hospitals, you have Infosys, you have Make My Trip, you have Travelocity. All these guys are our front end, their customers are able to book and their customers are able to, get jabs and get appointments. The most important part was the certificate, because we realized in the very beginning that, when you start traveling, people will look for a proof whether you have a vaccination done or not. And that certificate, we created a World Health Organization consistent, WHO, basically we are continuously in touch with WHO, and our certification process is absolutely robust process. A process which is verifiable, which is non-repudiable, and which you can verify. And today we are in a position where we have 117 countries we have a bilateral agreement with those countries where our certificates are recognized. And like others, we have also made our certificates also, verifiable certificate, non-repudiable certificate, QR code-based certificate. So this is what we have done. Now the statistics, I think we have had 1.72 billion vaccinations done thus far. 90% of our eligible population has been fully vaccinated. We have given first dose to 956 million, close to 1 billion. Second dose to 750 million. And of course, in one day, single day, we put 25 million vaccinations. So that's the scale. And we are also recording, by the way, we are also recording the AEFI, the adverse impact of vaccination. So we have a real-time data of the total, people, what are the adverse impacts. And now we have an analysis as to drug-wise impact, dose-wise impact, adverse impact. So that is also being captured real-time online on the platform. So essentially, we have created a situation where there is a single source of truth. Otherwise, everybody was saying, oh, I've done so much, I've done so many, I've done so many. There's no proof that you have done so many vaccinations. And, in our country, everybody wants to give press statements to say, oh, this is what we have achieved. Now, the achievements are all visible online, real time. I don't know whether you have seen the dashboard of COVID. Dashboard of COVID is like a ticker, it tells you real time online, sort of stuff. Maybe if you have a, you can probably dashboard.covid.gov.in. You must show to the participants in this of summit as to how the whole thing works. So therefore, and you can drill down to a hospital level. And more importantly, it's a truly public-private partnership. It is not as if the government hospitals alone are delivering the vaccination. The private hospitals are delivering the vaccinations. Now the vaccinations are being delivered in communities, in the, what is called the societies, and every single jab is recorded. And every single jab. So basically, we have created an extremely interoperable, frugal, and scalable system. At one point in time, we were recording, by the way, when you have 2.5 crore or 25 million vaccinations per day, if you just divide it by 8, and then, if you divide by 8, it becomes 3 million vaccinations per hour. And if you divide by 60 minutes, it becomes 50,000 vaccinations per minute. It becomes about 1,000 vaccinations per second. Yeah, this is what is having. So for example, we have vaccinated for 4.15 million vaccinations today. And we have, beautiful, you have, these are the statistics, and you have 1.72 billion vaccinations till date. And this is the progress today by dose, by age, last 30 days, you can do last 30 days also, by gender, by type, by drug, everything. And this is a coverage, dose 1, dose 2. So I don't think anything could be more transparent than this. So this is the power of an open architected technology. And then our Prime Minister, he told us, he called us and he said, look, this is what we have done. Now we need to give it to the world. Like we have given drugs to the world, we have given vaccines to the world. We have, for us, the old slogan, the old saying, Vasudhaiva Kutumbakam, the whole world is a family. We have been truly following that. Our Prime Minister, our country has been exporting vaccines to other countries, to other friendly countries. And this is what he said, why don't we make it into a digital public good and export it to anybody, give it to anybody who wants it. So what we did, and he asked for, he said, let's call a global conclave. And we called a global conclave on 5th of July, 2021. And 147 countries or their representatives participated in that. Almost the entire world, all the entire committee of nations participated. Many ministers participated in that. And there he declared that we are making COVID as a public good, a digital public good, which we have many. We have UPI, we have Aadhaar, we have many digital public goods now, and these goods are working at a scale. So now what we have done is we have made this entire thing as an open source, number one. Number two, we have created an open source documentation. This is country agnostic, which means you just have to customize and configure this. And this can be deployed in any country in the world, number one. Number two, what we have done, we have also trained many partners, many consulting firms and partners, and we have given them certificates saying that these people can be, their services can be used to configure and customize this software in any country. So this software, friends, is available in any country. We already have, more or less 12 countries are on the verge of signing the MOU, for putting it down and sort of establishing it. It is a completely web-based and completely open source. It's completely, you can modify it, you can do whatever you like with it. That is available as a digital public goods. And any country, and I'll invite my friends from Africa, in the NHA, we have a clear cell in the Ministry of External Affairs. We have a clear point of contact where you can contact and you can just say, I want this software. For example, we are having discussions with a number of countries on the same, and we have been giving them seminars, workshop, one-to-one, telling them this is how you can, customize it and install it. So I think this has been our experience thus far. And I think what we are now doing is something very interesting, and I want to leave that thought with you, is that we are repurposing COVID for various other public health programs. So for example, universal immunization program. Now we will monitor each child's vaccination, each child's polio doses, each child's diphtheria doses, or whatever other doses are given to that. So that's one part. We are creating an open, interoperable blood donation ecosystem in our country. Organ donation ecosystem is what is going to be created. So I think this whole program, whereby on the one hand you have users, on the other hand you have providers, and then how you can connect them. So it's not a digital commerce kind of situation. It's not a e-commerce platform, but this is a platform which is a digital public good and which should be used in an interoperable way where everybody can plug in and actually create magic out of it. Thank you very much again for inviting me.
Thank you so much, sir. Actually, I had few questions, but now they've become useless because you've answered most of them in your talk. But let me take a step back and first of all congratulate you on the outcome. The numbers are staggering. That talks about what would have gone behind it. If you talk about the numbers that you mentioned in terms of the number of people who sort of registered, the vaccination, and we saw some of it on the screen. And personally, as a healthcare investor, there are quite a few companies that we've invested in, which is sort of now using COVID, the open architecture that you've allowed, and then become so, made it so transparent. And I personally gone through the open architecture 12-page document that you have on the website. It's just mind-boggling. So a big congratulations to you and your team. If I can just summarize and outline, those important points that you've made, starting with the challenge that you sort of started out with, back in 2020, June 2020 is what you mentioned of, how do you bring out this kind of a platform, addressing, 20% of the global population effectively. But I think what would have solved for you is sort of the clear objectives that you mentioned. Because if you have to solve a complex problem, unless you crystallize it and distill it into a very simplified objective, you can't solve for it. So when you mentioned about it should be inclusive, easy to use, multilingual, transparent, do away with the entire information asymmetry, and more importantly, make it future ready by creating this open architecture and then making it inclusive, allowing private companies and private setups to partner with, I think was why it became so successful. The approach that you took to create this platform, the partnership model of PPP, which will again extend the life and use of this kind of a model. And more importantly, how you further repurposed it. These are commendable things. And I think that goes to talk about how now the government is looking at these kind of models, that if it's successful in one sort of situation, how do we extend it and make it successful? And a sector like healthcare needs that kind of an approach, that kind of an architecture. The problem that we are solving in healthcare for the population that we are solving for, if you talk about India, if you talk about other emerging markets, and if you talk about, Africa, this is the approach that will make it successful. So very, very important points. So I just have one question, since you've answered most of them. How in these kind of situations and for the objective that we are trying to solve for, how do you balance, things like data privacy and the need that we are solving?
Absolutely. That's a very good question, Sunil, and it's in everybody's mind. As you know, in India, privacy has been declared as a fundamental right by our Supreme Court, and therefore it's very important that we guard the privacy and security and confidentiality of the data. So we have done some principles. There are some principles of data ensuring data security and privacy, and these are larger principles. And actually, I can pontificate on these principles because we designed Aadhaar. I was the Director General of Aadhaar starting from 2009 to 13. And actually, by that time, we had issued about 600 million Aadhaars, the unique identity, digital identity of India. Now, there we had a concept called privacy by design. And the privacy by design is a very interesting concept. It actually talks about, one, minimal data collection. Don't collect anything which you don't require. So, for example, in COVID, we collected mobile number, we collected name, gender, and year of birth, not even a date of birth, no address, nothing. You are just tell me who you are, that's all. And of course, one proof of identity, whatever you want, that you have to show and you have to upload. So one is minimal data collection. That's one important principle. Second is consent and notice, which means you take consent at every state of the data principle, of the data person whom the data belongs. So secondly, as and when his data is used, immediately inform them. So for example, immediately after vaccination, we inform the person through SMS, Mr. So-and-so, congratulations, you have been vaccinated first time, this time, your next dose is due on this time, and then you can come. So, and therefore the person knows if somebody impersonated him, he or she will immediately know, oh, somebody has got vaccinated in my name. He will immediately complain. So essentially consent, notice, minimal data collection, and then of course, whatever we do, we put it in a real, encrypted form. The data must always remain encrypted. So the data at the back end is completely encrypted at all times. Let me put it this way. And it is encrypted with what is called 2048-bit encryption. And we always, for example, even the QR code is actually can be opened by the public key of the government of India for this purpose. So you can't just sort of read the QR code through a normal, iPhone or anything like that. So everything is security is taken care of in the design of the program itself. So that's something very important. And of course, in India, we have it's a democracy and it's a very vibrant democracy. People just, one day said that 150 million people's data is available on the dark web, the vaccination data. And then we found out it's a complete hoax. Not even a single data has been leaked either from Aadhaar, and it has been 10 years, nor from COVID. And I can guarantee none will happen. And people's data is absolutely safe, secure. And the only data which we have about people is their name, their gender, their year of birth, which is required for vaccination, and then the, the phone number. That's all we have. And we will keep it safe. Thank you.
Thank you so much, sir. And commendable work by your agency, by the government of India. And as you mentioned, rightfully so, our Prime Minister has said that, if we have this, let's give it to the world. Thank you so much. And with that, we would move to the next session. So back to you, Julia.
Thank you so much. I would like to thank Dr. Leah Desi, Dr. R.S. Sharma for sharing their valuable insights with us. And thank you, Mr. Sunil Thakur, for facilitating this discussion. For our next keynote address, I will request Mr. Ashwajit Singh, Managing Director, IP Global Limited, to be the facilitator and introduce our guest and the topic.
Thank you. Good afternoon, delegates, organizers, participants of this very, very important summit, the Indo-African Summit around, vaccination. And there couldn't probably have been a more timely as well as needy summit as this, because over the years, we've all seen that if we have to really scale up beyond a particular country or scale up in the world. And today we all know that any pandemic or anything that happens in one part of the world does affect the other. So if we have to scale up across the world, it is extremely important to look at South-South collaboration, because whatever challenges that India faces would be quite similar to what Africa faces. Whatever solutions that Africa or India are able to get would be replicable and applicable to the other country as well. So there are a lot of lessons that can be learned. There are a lot of areas of collaboration that can be done. And when we talk about scaling up and ways to sort of further the vaccination, I think it's very important to learn from each other's experiences and take this further. Before I sort of get into introducing the speakers, I was just doing a little bit of looking at some data, and it's interesting to note that in terms of actual COVID cases, India's had nearly four times the number of cases that Africa as a whole continent has had till date. But when it comes to the actual deaths, India's got about twice the number of deaths that Africa has, which really means that half the number of, India has been able to avert perhaps half the number of deaths that could possibly have taken, given the fact that we have similar situations, because of perhaps the immense or the large scale of vaccination that's been done. So I think it's now been proven beyond doubt in a number of studies that vaccination does have a very major impact on being able to, at least if not avoid the COVID or the Omicron, but at least to minimize the symptoms as well as the chances of fatality. Now, Mr. Arish Sharma and as well as Dr. Leah Tedesa, I had Dr. Sharma, and she had both mentioned about the scale that's been done. India, as we know, has done more than 1.7 billion doses, with 53% of the population being fully vaccinated in the largest vaccination drive across the world. I think, but let me start by challenges, which perhaps quickly talk about the challenges which are similar to both countries, which was really, both regions, which are lack of trained staff. Both India and Africa have limited trained staff, even though both countries have been able to have huge immunization experience in other diseases as well, and have been able to use that. There has been the issue of, when we talk about India, while we do have better internet connectivity, but then we have to remember that 2/3 of our population really lives in rural parts of the world, rural parts of India, and that may not have the same kind of bandwidth. So we've had bandwidth connectivity, because while we did hear about the use of COVID and some of the other IT solutions that India has done, I think the important thing that we managed to also do is address the bandwidth and connectivity issue. The vaccine hesitancy, of course, is similar across both regions. We've had to create awareness and go through that. Then, of course, challenges around cold storage, logistic challenges, and more important, how do you actually get the vaccination to the last mile, to the last person? Both countries have faced that. And also, looking around issues around wastage, low shelf life, which has been there. Those were, of course, the challenges that both parts of the region faced. But at the same time, India was able to have some advantages, because India is the largest manufacturer of vaccine in the world, and all the vaccination that India has needed has been manufactured in-house within the country and at very low cost. I think India today is a manufacturer at the lowest cost across the world. We've managed to reach the last mile. We have done that through the use of technology. We've done that by doing a phased approach, which is very important, where we started with the health workers, frontline workers, the elders, then the adults, and then finally the 15 to 18 age as well. We have worked around innovation, and they are in the panel discussion. You will hear about some of the innovations. We are involved at IP along with the USAID on Samrit, which is looking at a lot of innovation. And I'm pleased to say that the number of innovations in the health sector around COVID has been huge. India has had around so many startups and innovations around. as well as working around the awareness and hesitancy that's taking place. Africa, on the other hand, has some bigger challenges. They are still struggling with some of the challenges. We've seen that 21 countries in Africa are still under 10% vaccination. There are challenges around, syringes, logistics, storage, and wastage, etc. We'll hear more about that. So I'm not going to take any more time. I'm going to be introducing the first speaker, Mr. C.K. Mishra. We've not yet had Dr. Susan Machocha, who's not been able to join yet. I believe there's some connectivity issue. Hopefully she will join, but as of now, I'm going to be asking Mr. Mishra. Now, Mr. Mishra is somebody who actually has the entire perspective of being from the health sector as the he's a policymaker, having been in the IAS and the government of India, to somebody who's then moved on post-retirement to being the senior advisor of the Serum Institute, the world's largest manufacturer of vaccine, as well as he's on the advisory board and the board of directors of IT Global, which is working for Samrit. And he's also very involved in looking at some of the innovations that have taken place around this sector. Mr. Mishra is a former Health Secretary, Government of India. He's a former Secretary, Environment, Forest and Climate Change, Government of India. He's somebody who's worked, in the Ayush as well. And he was also the Additional Secretary and Mission Director of the National Health Mission, which is the largest public health program globally. I remember having known Mr. Mishra for over the years. I remember when he was the Additional Secretary NHM, he organized or chaired the Call for Action Summit, which was, in fact, the keynote address was by the Prime Minister of India. And we had over 20 health ministers from various parts of Africa who participated in perhaps the biggest global meet on any issue relating to health and nutrition. That was there in New Delhi about 4 years ago. So he's somebody who's got the policy experience as well as the private sector experience. So we're going to go straight into Mr. Mishra's address. And thank you for joining us, Mr. Mishra. It would be important for us to learn how India has been able to get over this vaccine hesitancy. I'm aware that when COVID took place, you were asked by the Prime Minister to chair the committee at that stage, which was to look after infrastructure and creating. India had zero infrastructure, be it masks, be it hazmat suits, etc., and beds as well. So you started off with that role being on the side of the government, and you transitioned into Serum Institute and now Samrit. So it would be very important to hear from you what worked and what didn't and what your experience was. Over to you.
Thank you, Ashujit, and thank you for that introduction, and thank you to all the organizations, Nat Health, the African Federation, and the Knowledge Partners IP Global for organizing this, because this is a forum where we can actually share. And if there is a success, there is a knowledge, it must be shared. So such interactions are going to help each other. And as Ashujit was saying, in the South-South cooperation, to make things better for humanity, so to say. So, if you look at, we just heard Dr. R.S. Sharma, an incredibly fascinating story of COVID and technology that India used to ensure that the vaccine actually reaches the arms of everyone who's entitled to it. And we heard it from the architect himself. But let me just shift the canvas a little and talk a little differently about what really vaccination means and how is it that it has suddenly found the kind of prominence that it has today in the pandemic situation. So to understand this, let us try and understand what really worked in the pandemic. Every country across the globe was trying different things, experimenting with things. It was a trial and run kind of a thing where different things, we were learning as we were looking at things. So it was a continuous process of experimentation. But if you try and distill things down, there are two things which really had an impact across the globe uniformly. One was lockdown, and the other was vaccination. Lockdown may have, kind of inhibited the progress of the virus. These people got less infected, but it had a very sad end in terms of the economic adverse impact and social impact. So can certainly not be the preferred mode. Vaccination has been one vehicle which has managed to really succeed in a big way in containing the pandemic. And today, globally, we realize that this is the best tool to go ahead. And the globe actually has really done well on this. But if you look at India, let me just spend a minute on India. If you look at India, this foundation was laid when India did the huge routine immunization, when largest number of children across the globe were being vaccinated in India. Then we launched Mission Indradhanush in 2016. New forms of vaccination came up. So there was already some kind of a foundation which was ready. But it was not exactly what we saw in the vaccination campaign during the pandemic. The reason was that that is a routine immunization for children who are known to us. This was an emergency immunization. At a time when we had to have larger numbers, we had never experimented with adult vaccination except for a very small bit with JE in few districts in India. Therefore, it was a new challenge. And when this challenge came up, we innovated on several levels. New responses emerged, and we were really able to capture the entire spectrum of work that is required to vaccinate a person and secure his life. Originally, even when we had the routine immunization, the phrase that we used to use is that if a vaccine can save a life, let not a single life be lost. So that is the critical importance of vaccination that we have seen. If you look at the entire gamut of operations, there are 4 critical legs, according to me, which we need to look at. And these 4 legs, in a way, are challenges as well. The first one would be, in this scenario, the research. If you look at the past vaccines of the world, they took years, 5 to 6 years minimum, to really come up with a vaccine. Here, our scientists did a commendable job across the globe in coming with quicker solutions, and vaccine was brought to the fore. But the larger challenge that followed is the second one, and that is, having found what kind of a vaccine we want, what is our production capacity and production capability? So the production ability came to fore. Fortunately, India in particular had that ability in it to take it, because traditionally it has been one of the largest vaccine producers anywhere in the world. So we were able to take this head on and start production. Then came the question, and that is the third pillar. You have produced the vaccines, they are there with you. How do you deliver to such a huge population? And if you look at it globally, it's a huge task. So then you had to create new delivery mechanisms. The routine delivery mechanisms would not work. And therefore, you had innovations in how to reach, where to go, how to get to people. New tools were created. New institutional systems were brought in, where you would reach a vaccine in a particular way. A new data set was created. And when all this was done, the fourth critical element came into play, and that was tracking. Unless you are able to track who's got the vaccine, who's got the vaccine on time, who's got the vaccine in what form, you may not be able to succeed. Therefore, you just heard about COVID. So technology became a huge enabler. I do believe that technology is a very strong tool which pushes healthcare delivery. But for all practical purposes, healthcare delivery is not equal to technology. There's much more than technology that takes to deliver healthcare and deliver vaccines. It's a lot of human effort. It is a lot of advocacy. It is a lot of communication if you really want to reach the vaccine. So in this scenario where the world was struggling with this, one critical word that everybody was talking about was global collaboration. Here we are talking about the South-South collaboration, the collaboration, our ambassador just mentioned the collaboration between India and Kenya, similarly with other African countries. But we were looking at a strong global response, which was collaborative in nature. If you ask me, we did not come fully true to it. Because then the race began that country which is producing must vaccinate its people first. It is very well understood, since it's a local production, people have the first right. But in the process, what we missed was equity. The core of healthcare shall always remain equity. So regions which were unable to produce, did not have the capacities either to produce or to procure, were left behind. Slowly these things are now getting better. But I think initially we faltered hugely on equity. And particularly Africa as a continent, I think initially was very low on the level of receipt of vaccines, which I think WHO and Gavi had a major responsibility and role to play. But in this entire equity game, we need to understand one fundamental question, that if the virus survives anywhere, it survives everywhere. You cannot contain virus in one particular geography of the world and think that the problem is over. It has to be a global containment. So everybody has to come on board. So this was one thing that we really need to understand. What is the critical question about vaccination? Even if we have the vaccines, do we have the wherewithals to really reach the arm? Unless the vaccine reaches the arm or the arm comes to the vaccine, as they say, you cannot have a success story. And this is where huge amount of innovations came in. Mr. Ashwajit Singh was just talking about the USAID supported Samriddha program. Small entrepreneurs, sharp entrepreneurs came up with sharp ideas on how to reach vaccines. And this is something that we need to really share at a global level. How is it that we are actually able to go to the people and carry vaccines with us? And all kinds of innovations happen in cold storage, in temperature maintenance, in storage, in transportation, and in actual delivery. But the delivery also has pointed to the world another issue which on a long term we'll have to address. That is the huge issue of human resource and capacity building. So this vaccination story has given us a lesson for future that we must carry with us. And if you are not able to deliver to the arms and on time, this vaccine would not be such a big story. But today, since you have reached vaccines to most of the people, safety has been ensured. In the third wave in particular, yes, it was a nightmarish thing when more and more people got infected. But we did not lose that many people as we lost in the earlier waves, which is a signal that vaccine worked. And vaccines have worked throughout, whether it was the initial vaccine for polio or, I mean, one has seen innovations and daredevil acts of reaching polio vaccine on animal backs so that it reaches the last mile. So vaccination of everyone, every eligible person of a particular age as far as COVID is concerned has been very critical, and we need to really collaborate on this. And some of the successes that we have got because of that innovative age, we must share with all the countries, particularly the African continent. And let me tell you, there are some brilliant success stories on that side of the field as well, which we need to learn and we need to imbibe. So what is it that really came in the way in some of the countries of vaccination? By and large, vaccines were available. There were people willing to deliver it. There was a mechanism of delivery, but there was still a sense of hesitancy. Today in Europe, you're seeing huge protests on vaccines. I'm not getting into any debate because scientists have proven beyond doubt that vaccination is one thing that has worked very well. But then hesitancy will come. One has seen it in earlier times as well in routine immunization. But two factors that have really addressed the issue of hesitancy are advocacy and communication. And communication becomes a very key element because that is the way you reach people. And what is even more important in communication is the design that you give to the communication. How do you reach people? You have to convince the person that the effort is to save the life. And I think that is what governments across the globe today are doing. If you look at the entire scenario of disease, infections, it is the vulnerable who are the most impacted. And it is not just the population of a country which is vulnerable, which is the most impacted. The vulnerable countries also, geographically, globally, are the ones who are most impacted. Therefore, it becomes a matter of responsibility for the world to look at the vulnerable countries and ensure that vaccination is done there properly and they have enough resources and vaccines and materials available to vaccinate. Because one doesn't know how the virus is going to behave in future. But what one does know is that we have found a protective wall which at least prevents life. So we must use the wall very well. And it is here that I would like to mention that we must look at this platform of India-Africa relationship. We must seriously explore possibilities of experience sharing. The problem with the globe so far has been that some brilliant work has been done, but has stayed where it is done. Even if you look at the entire scenario of vaccination, when technology remained where it was not shared, goods remained where it was, it's not shared, at least
I think we seem to have a network problem, Mr. Mishra. Mr. Mishra?
Yes, sir. I think we have lost Mr. C.K. Mishra. Sir, are you there?
I think we've lost him. So I think he had more or less finished. I think he'd probably log in again, but I think he has more or less finished his points. I had a few questions, of course, which will need to wait till the time he gets back in. Are you back, Mr. Mishra?
Yeah, can you hear me?
Yeah, we lost you for a half a minute. Yeah.
So did I. But anyway, what I was trying to say is that, such relationships where sharing of success is of a critical nature must happen. We need to continue to learn. This vaccination journey has not been an easy one. But let me also say that this has been a rather successful one. So we need to learn from it, take the good takeaways from it and share it with others, and together build capacities. It has to be global capacity. You cannot win this game with individual country capacity. So let us move towards that global partnership. Thank you very much.
Thank you, Mr. Mishra. I think as always, it was extremely useful, right from the policy maker to the other side. You've also, since you're no longer with the government, with the private sector, you were able to also pick up some issues which needs to be done to really further this in a dispassionate, independent manner. I think some of the points you made were very, very useful. Of course, the two major things that have helped fight this pandemic to the extent we have been able to do that is, first is lockdown, and now, of course, the vaccination. So those are the two real game changers. And again, I think the one country learned from the other in terms of experiences of lockdown to vaccination. And perhaps now we're reaching the third stage of really some countries going back to business as usual, but we don't know the results of that yet. So we'll wait till that happens. Of course, the impact of the lockdown was different in various parts of the world, both in terms of losing on lives as well as livelihoods. But hopefully the worst is behind us now. You also made a very interesting observation about how this vaccination was very different from some of the other vaccinations we've seen till now, because it was an emergency vaccination where you really started off with the adult population, and most of the vaccination drives that have taken place earlier have had enough time for research, have had enough time for looking at immunization. But here it was emergency and to adult population. You also spoke about production and delivery mechanism, as well as, of course, being able to track. So I think the 4 Ds that were challenging are really the demand, the data, the delivery, and of course the doses that are there eventually. In India, of course, you were able to overcome the doses side because of our own manufacturing capacity. And finally, of course, Dr. Sharma just mentioned about the tracking system and the IT that we really had. So that helped in tracking, as well as, of course, the capacity building that India has been able to do through some of our other programs. We've had been leaders in immunization, and we were able to sort of look at that. But I think the very important point that you made here was that we all know there is a need for global collaboration as much as, of course, the South-South collaboration. But the one major point I would say you pointed out, and it's good to hear somebody say that, is that global collaboration did not take place to the extent that it should have, even though you had the COVAX, you had WHO, you had Gavi really stepping in there. But that would have probably, that is something that could have been done better. But of course, you also mentioned about the issues that countries had in terms of first being required to vaccinate their own people before moving in. And you made a very right statement that if the pandemic or the disease survives anywhere, it will survive everywhere. We've seen that, be it the Delta wave, be it the first wave, be it the Omicron, that even if it's there in any one part of the world, it's only a matter of time before it reaches the rest of the world. Some of the issues which you might, I'm just going to give you another 3 minutes to try and address some of the issues before I come in with the final point, is now that you are there involved with the Serum Institute, I would want to hear from you, would the Indian manufacturers be open to try and look at going into other regions to set up manufacturing capacities as well? Exporting is one, but are we ready for market access outside as well? Are we looking at non-injectable vaccines coming in soon? Because that might be easier to really reach the last arm as well, or the final arm. Do you see, what role do you see of the private sector when it comes to vaccination? So I just want you to speak maybe a couple of points on minutes on this as well.
See, the issue of setting up facilities outside one's country in terms of manufacturing is a very relevant one. And I don't see any reason why companies would hesitate to go out and set up if the environment is conducive enough for them to set up. But we need to also understand that it cannot be a COVID-specific response. It has to be a long-term vaccine manufacturing response, which includes several vaccines. And I think there is generally a need for dispersal of manufacturing facility, both from logistic point of view, as well as geographical equity point of view. And I see no reason. You see, at the end of the day, if enhanced manufacturing capacity has to take place, it need not take place by additional enhancement at the present location. It can happen elsewhere. Some conducive environment, and let me be very blunt, some inducements will be required for companies to move. That's the way the game is played. The private sector has an extremely critical role to play. Particularly in India, we've seen the private sector's role in production hugely. Then, as a country, we and next where in the go counted on the private sector for delivery of vaccines. That did not work out very well in India, and the private sector was able to do only 7 to 8%. That's the reasons are somewhere else to find when you have a free vaccination campaign going on. People's capacity to buy or people's desire to buy a vaccine are reduced. Therefore, the private sector could not do very well. But where the private sector's role becomes very critical is in the delivery mechanism, in the maintenance of cold chain, is in the innovation, is in the investment in actually creating transportation systems for vaccines and enhancing production. So the private sector has a huge role to play. And even technology that Dr. Sharma was pointing out right now. At the end of the day, you need to get partners from the private sector to enhance that and to reach it to everyone. It's not about conceptualizing, it's also about aggregating and disbursing. So the role of the private sector has been very critical and will remain very critical in many countries and also in India.
Sure. Thank you. I think that's very useful. And I think the most important underlying message that's been given in both sessions till now has also been, besides, of course, the nitty-gritties, is the need for leveraging the experience of one country, one region into the other, the use of digital technology for delivery, tracking, registering, etc. And finally, to look at forming collaborative partnerships, be it between two countries, be it between two regions. It could be a South-South cooperation, it could be a global cooperation, it could be a cooperation at the government level, it could be collaboration at the private sector level, it could be collaboration within African countries, it could be collaboration with the not-for-profit as well, and of course, collaboration with development financial institutions as well as bilateral and multilateral agencies. You also mentioned about the need to learn from each other. So I think you've made my task of introducing the next speaker very, very simple, because when we talk about learning from each other's experience, I don't think there is anybody, who's probably worked in more countries on this issue than USAID. So thank you, Mr. Mishra, and I'm extremely pleased to introduce our next speaker, Ms. Anjali Kaur. Thank you, Ms. Anjali Kaur, for first of all having accepted our invitation early morning. I can imagine it must be very, very early morning in the US. So sorry for having got you up so early, but perhaps that's the only time that worked for both India and Africa. So thank you for joining us. I've had the pleasure of course, meeting Ms. Anjali Kaur, who's the Deputy Assistant Administrator of the Bureau of for Asia of the USAID. She again comes with a very all-rounded kind of experience. She's an international development professional. She is a senior policymaker at the USAID. Before that, she has worked as a senior program officer for the Bill and Melinda Gates Foundation. So she's actually led some global policy and advocacy strategies on HIV and TB programs. So see, somebody who's worked not only in the sector, but worked both at policy as well as execution on the ground level. Having, of course, interacted with her personally, I can say from experience, she has a very quick understanding on issues, because she was able to understand some of the complexities of some right away when we spoke about that, and a clear sort of approach to find solution and result rather than sort of leave a thing at the policy level itself. And part of that, of course, is to make sure that the solutions are sustainable and long-reaching and have some kind of a leveraging and advantage beyond what they were really meant for. So thank you so much, Ms. Anjali Kaur, and I'd like you to please tell us a bit about the lessons of USAID. You've done a lot of work across the whole world, especially around how you've the lessons learned and how you think that could help in terms of collaboration for strengthening the COVID vaccination. Over to you.
Thank you so much, Vishwajit, for such a kind introduction and for bringing us all together. This is such an amazing experience and platform to be able to discuss these very critical issues. Good morning, good afternoon, and good evening. It's a pleasure to be with all of you today on behalf of the United States Agency for International Development, better known as USAID. Since the outset of the pandemic, USAID has provided more than $9 billion to intensify the fight against COVID-19 around the world. I'll share a few examples from our India mission today, which could serve as models for the government and the private sector to scale up within India, throughout Africa, and around the world. USAID is supporting India's COVID-19 vaccination campaign with a focus on reaching the unreached, as part of a suite of support that is strengthening India's overall health systems. Perhaps most importantly, these initiatives are making a real difference in people's lives. For example, Rashmita Sahu is from the eastern state of Odisha, a state in which 1 in 3 people live in poverty. Rashmita is physically disabled and felt hesitant to get vaccinated, fearing the vaccine might add to her disability. Through USAID's work to combat vaccine hesitancy in vulnerable populations, a team visited with and counseled Rashmita, taking a personal approach to address her fears and explain how the vaccination is safe for all, including people with disabilities. USAID helped to connect Rashmita with the Government of India's door-to-door vaccination program for hard-to-reach populations, providing her a vaccine at home. They assured her that a local medical officer would be there for her if she did experience any side effects. This people-to-people contact bridged the gap, and as a result, Rashmita got the protection she needed to stay safe from COVID-19. Importantly, this is just one of many examples. Our work serves as models for the government and private sector to replicate and scale, not only within India, but across the globe. For example, in January, USAID partnered with local Indian governments and leveraged more than $1.3 million from the private sector to launch a mobile vaccination program, deploying more than 90 mobile vaccination vans to increase vaccination coverage in hard-to-reach populations. We reached nearly 500,000 people in less than 45 days. Notably, for today's event, in September 2021, USAID launched the City-to-City COVID-19 Vaccine Learning Exchange Program with the Government of India, which is bringing together 5 Indian cities, Delhi, Mumbai, Ahmedabad, Indore, and Bhubaneswar, and 10 cities from Southeast Asia and Africa, including Nairobi and Addis Ababa, to facilitate sharing of best practices and knowledge tools as the world races to get as many shots in arms as possible. Importantly, we're also harnessing innovation. In 2020, USAID collaborated with public and private partners in India to develop the Samrid Blended Finance Facility, which combines public and philanthropic funds with commercial capital to create and scale health solutions, reaching more than 20 million people in India through innovations, including temperature-controlled shipping containers for vaccines and mobile health units. Thanks to collaboration with today's event host, Samrid is extending vaccine supply chain supports in Africa, which will help increase vaccination coverage in hard-to-reach areas. I'll close with one more story. Tribal communities in India have statistically low vaccination coverage. Thus, USAID is utilizing creative methods such as door-to-door outreach, multimedia community radio, and street theater campaigns in local tribal languages, featuring information on COVID-19. In rural Assam, a remote area in the northeast region of India, USAID is training local community members, including many women, to serve as health messengers who promote health awareness and COVID-19 appropriate behaviors in their local language. Julie Lakhar, a member of the local Garo tribal community, said, "The lack of proper healthcare facilities and health-seeking behavior distance the vulnerable population from availing quality healthcare." However, in her role as a health messenger, she's equipping her community with accurate and reliable COVID-19 information. People Julie has worked with are overcoming their fears and getting vaccinated. Through our training programs, USAID helped reach 560,000 plus people across 10 districts in Assam with critical COVID-19 information. As we all know, equitable global access to COVID-19 vaccines is critical to control and end the pandemic, save lives, and revive economies. The US-India partnership and India's vaccination program experiences offer many lessons that we hope to share with other countries in an effort to fast-track their vaccination efforts. By coming together as a global community, we're able to maximize our impact and offer valuable insights, making India and the world a safer place for people like Rashmita, Julie, and millions of people like them, who depend on leaders like us to create a better, healthier future together. Thank you again.
Thank you so much, Ms. Anjali Kaur, for telling us about the number of programs and direction and areas that USAID has been working in India and of course other parts of the world as well. And thank you once again for getting up so early. That was very useful and insightful. And thank you, Mr. C.K. Mishra, for your remarks on vaccination as well, and your entire sort of approach of understanding it from one end to the other. So I think between the two of you, you've really given us an overall perspective of not only what the challenges and issues and solutions of vaccination are, but also the need for us to collaborate and learn from each other. Thank you so much, both of you. Over to you, Juliet. Thank you.
Thank you so much, Mr. Ashujit Singh, for facilitating this discussion. Moving on, while addressing vaccine hesitancy and uptake of vaccines by increasing the participation of private sector and blending their capabilities with the public sector is important, it is equally important to have sectoral and cross-country learning while also exploring collaboration for improving the vaccine access. And to talk about some of these pertinent points, we have an expert panel lined up next. This session will be chaired by Mr. Sanjeev Navungal, Managing Director at Bharat Serum and Vaccines Limited, and moderated by Mr. Gautam Chakrabarti, Development Assistant Specialist from USAID India. Our panelists include Dr. Willem Akwale, Ministry of Health Kenya and lead of the Vaccine Task Force, Mr. Rahul Mehra, Chairman and Founder, AWL India Private Limited, Mr. Samit Jain, Managing Director, Plus Advanced Technologies, and Dr. Eva Nyanga, Chair of Medical Practitioners and Dentists Council in Kenya, and Ms. Carol Kariuki, CEO of Kenya Private Sector Alliance. I request Mr. Sanjeev to give the opening remarks. Mr. Sanjeev, you are on mute. Please unmute yourself.
Good afternoon, everyone. And first of all, let me thank the organizers for organizing such a timely summit for the right time to discuss the vaccine collaboration between India and Africa. And we were we have a very, very strong panel. So it is important that I keep my opening remarks to the minimum. But very interestingly, in the last about, let's say 2 years now, COVID in a way united the world in terms of showing that a public health or a public health disaster or a pandemic can really not discriminate between anyone, whether it is geographies, whether it is distances, age, nothing mattered for the pandemic to spread. On the other hand, as we are discussing COVID vaccines, very interesting that COVID vaccines actually divided the world between manufacturing countries and non-manufacturing countries. And this battle of haves and have not in access actually accentuated during this time. And somehow as a world, we did not find right solutions. For very many reasons, we in a way faltered in trying to ensure equitable access. Public health is all about equality, and Mr. C.K. Mishra also mentioned the same, that having equity in public health is very, very important. If transmission of the disease can make no difference, why should public health solutions make any difference in terms of equality? It's very important that this kind of disease, also a viral infection, tells us that to protect ourselves, we need to protect everybody else. Only if others are protected, I am protected. And this simple principle got lost in the situation where boundaries of countries became slightly more important than anything else. And in between all this, we need to now start ensuring that we commit to equitable distribution, because doing that means that we protect the world and each one in the world. And that's probably a very, very important point. India actually managed reasonably well to protect its citizens. And India probably is in a better position now to help many countries, support many countries in the public distribution of vaccines, and India must take lead. Fortunately for us, we already have 4 companies who are manufacturing vaccines and have approvals. And we expect the 5th one to come in a few months' time, not very long. So we will have 5 companies who can supply, and therefore probably India is in a much better shape. But for that to happen, it's not just about vaccine supplies. I think we heard Mr. Sharma talk about the COVID platform. So every country will need a good platform to ensure that the data is properly captured and safely transmitted all across the world for people to be well protected. We need practical experiences to be shared between countries where this has been successful, like in India, and to other countries, to ensure that the practical problems that we saw are not repeated anywhere else. We also need to understand that besides COVID vaccines, COVID related medicines need to be also equally, equitably shared. So it's not just about vaccines. I mentioned about technology already, and also how to operate in resource limited settings, which even India is a part of, to ensure that we are able to provide adequate support to other countries. I think let me stop here with my opening remarks. I will come back in the end to summarize the discussion, but we have very, very high quality members on the panel. So I, including the audience, must be really waiting for others to take over this panel. And I hand it over to Gautam and Julia to start the panel discussion. Thank you.
Thank you so much, Mr. Sanjeev. I would now hand it over to Mr. Gautam to start the panel discussion.
Thanks, Julia. And thank you, Mr. Sanjeev, to really lay it out. And the important point that you actually brought out is how this COVID, although affecting almost everybody across the global, the world almost similarly, but how people and the countries are getting divided with this manufacturers and non-manufacturers, and how we can really bridge this gap. And I believe what we have heard today with leaders presenting their ideas and how they have tackled it, and the participants present here might actually offer a solution in terms of way forward, and how we all can come together in a partnership to really solve this issue. So I'm starting while starting this panel, I'll request all the members and others who are in this forum to really feel free to put their questions in Q&A. And towards the end, we will try to pick up a few. I don't assure that all the questions would get answered, but today, but maybe the panelists can get back to the people maybe by email or also in this chat. So While starting, let me first start with Dr. Willis. We know that you have worked quite a lot, especially in this pandemic, and looked at both the government and the private sector, how they can address this issue. So would really love to hear your thoughts on not only what has been done till now, but also how you look forward, how people both from public and private come together to solve this issue. Over to you, Dr. Willis. Dr. Willis, you are on mute. Please unmute.
Okay, sorry for that. And thank you very much, Gautam. Thank you, everyone, for organizing and inviting us to this very important summit. I think it has been a very refreshing 2 hours for me, listening to presentations, listening to opinions, listening to policy directions. And for me, there are 3 areas I really want to talk about. The first one is the one of demand generation, getting the vaccine to the arms, or bringing the arms to the vaccine. And really share the Kenyan experience. I'll then share the issue of data management, and then briefly just touch on the process of the future, where I see collaboration in terms of sustainability and looking at commodity security. So let me start with the process and say, like many countries in Africa, we didn't have enough doses. The very initial stages of our vaccine program, which will be 1 year old in 2 weeks' time, was basically driven by us using fixed vaccine posts that denied access to very many people. And because of global constraint that everybody knows about, we had a period that issues of equity were not adequately addressed. But 2 lessons we learned. One, towards the end of last year, once we got enough doses, we put in public health directives that would then require one to show proof of vaccination. Many people confuse that as mandates. They were really not mandates. Public health requirements are not new in this country. Even when we joined schools, we had to show proof of vaccination. Certain clubs, before you go to swimming, the same is required. So one of the things that then happened, we saw almost 2-fold increase in the number of people turning up for vaccination. Now, just about a week ago, we launched our mass vaccination using local leadership, using what we call the chiefs and the assistant chiefs. They have been given targets, and they started going from place to place with our vaccination teams. And what I can say, this has had a big impact. We have now seen the highest single vaccination in a day of 250,000 vaccinations in a particular day, and actually almost 2 million vaccinations done since the beginning of that exercise. Now, then, let me say about data management. And maybe as I sat and I listened to CoWIN and the capabilities and the functions that it can do, I actually thought we also have an unsung hero in Kenya known as the Chanjo KE system. I actually would want to say it, in a big way, has the same functionality as CoWIN. Some of them have not been made effective, but I'll list some of them. Actually, one, you can do the scheduling of your appointment, and over 1 million people have already scheduled appointments. The only challenge, of course, was the availability of vaccines. So it became a challenge occasionally for people who have scheduled and the vaccines are really not there. But with the stabilization of the supply chain, that functionality can be used. Now, the other issue has been to share data with our health information system, the DHIS2. And here what we have to balance is the issue of personal data against service statistics. Our laws don't allow us to share the personal data. So what we've done, we've made this interoperable. And now we can submit service statistics data into the DHIS, and now analytics have started to be done. What we've not really reached, but I'm told the team can do, is have that in real time. They are really working on it so that it is real time, and we should start seeing the beautiful graphs like we've seen on COVID. The other thing was the only issue of supply chain and event management, the adverse event following immunization. We realized that the pharmacy board had a better mature system for event, and interoperability between these two is now being worked on. So let me say that in terms of data management, we can see we are on the path of going. We may not be as mature, but definitely we have that scope. And what the IT team here tells me, the expansion horizontally still has a lot of space. Now, then let me come what I see the way forward in public-private partnership. I think the issue of consumables, you don't get vaccines into people's arm without syringes, needles, cotton wool, or if it's required, without the safety boxes, without capacity building, continuous capacity building in an effective way. And I see those areas as one that the private sector can really take a lead in. Those really are very crucial to sustain our program. And then finally is the production of the vaccine. And what here in Kenya, we are currently in the process of setting up our vaccine manufacturing plant. And the government has put in resources, but has called out on private sector that is keen on collaboration in terms of technological transfer and capacity building of the country. Because the lessons also we've learned from COVID, you really need to ensure that the goods are where the problem is as well. Thank you. Those are some of my thoughts.
Thank you, Dr. Willis. So I believe the three very important things that I take away from what you said. One is the data systems, which we do see that various countries, whether it is India or even some countries in Africa that you also mentioned, have their own data systems that they have developed, and we'll need to see how they can really talk to each other and not really become kind of competitive, because when we look at the global vaccine chain, these are some of the issues that we might need to face. The other very important issue that you really raised is the consumables and the other supplies that are needed for this vaccination and the role of the private sector there. And finally, I believe when this entire partnership comes, so given these things, I think the manufacturing and all other investments that are needed, let me bring in some people from the private sector and let's see what they have to say. So let me go over to Mr. Rahul Mehra, leading the AWL company and the efforts, important efforts in the vaccine supply chain and how that can be made efficient. And not only just the supply chain, but I think that will also touch upon in some portion what Dr. Willis was saying in terms of the data management and how the supply chain and data management can really be brought together. So Rahul, over to you for your perspective, please.
Thank you, Dr. Akwale, for bringing out some of the things which I can definitely share. And thank you, Gautam, for giving me an opportunity in such elite panelists and being part of such an important Indo-Africa Summit. So I would like to straight away talk about, I think, because a lot of things are already shared by Mr. Sharma while talking about COVID. Mr. Mishra as well spoke about the importance of technology and how the entire thing works. So while talking about COVID, the biggest takeaway in this entire business was getting people registered on a platform, getting unique identity, minimum data required to register, and getting accessibility to almost all the beneficiaries who want to get vaccinated. So now, before we even get to that, COVID, I think the way COVID worked, we were also in a, I would say, we were looking at a tool which can collate the consumables, which can collate the logistics, which can collate all the hospitals, which can collate all the primary health centers, which can bring in all the state governments, central government, and the entire government machinery, so that we can give the medicines, we can reach to the last mile possible. So our journey started way back COVID-1 when it was way back in April 2021. The journey was simple, I would say. it was all about learning. We never thought that we'll get such a big, massive opportunity to manage a country, 7th largest geography, 28 states, 8 union territories, and 736 districts. So the fascinating part about the entire journey is that we learned. Every COVID, Delta taught us a lot. Omicron made us ready. And now, because almost 1 billion people are vaccinated, so our infrastructure is almost ready. So we can share a lot of things. We can replicate the same stuff because Africa, almost 50 plus countries, similar structure, population requirement. I think only 11% of the people are vaccinated. And there is almost the same demography and the same way people are working. So the first thing was to create an infrastructure. So first thing what we did was we went onto the whiteboard, we created a system where everything from what we received, be it consumable, be it vaccine, be it tocilizumab, be it remdesivir, we should know and create a visibility. A visibility between state government machinery, central government machinery, hospitals, doctors, health workers, and the people who are supplying the stuff. All the Pfizers, all the Red Cross, all the NGOs who are there in the frontline workers. So what we did, we created a tool which was named as Chakshu, a dashboard as was spoken by our Honorable Highness Dr. Paul, that Maitri is a word friendship. So Chakshu in Sanskrit means eyes. So they wanted to have an eye over entire supply chain. So this dashboard was created. We created something in for Ministry of Health and Hindustan Latex Limited, whereby we gave them a visibility of what was coming in. So we were receiving, say, 1 million PPE kits. So people should know. Now the second step was, now we have PPE kits, which all geographies and which all parts of India we should get them. So we started working on different states. We started working on the last mile. We started evaluating the beneficiaries. We started looking at the data of the people who were affected by COVID in all those states. So now comes the time of creating warehouses and creating infrastructure. So that was done. Now the next step was bringing in the stuff and what to be allocated. So we created a tool where everyone, all the users sitting in the central government and state government, can communicate to and fro. So if somebody, a West Bengal or a Haryana or a Delhi or Chhattisgarh, different states in India, if they wanted 100,000 PPE kits, they wanted 200,000 gloves, they wanted 500,000 goggles or coveralls, so they can allocate by looking at the inventory at a larger level. So we created a supply chain where people have access to what they want at a state, at a central level. So while I'm talking, it's not about doing some warehousing distribution for Zara or for a private label where we have 200 stores. We're talking about real term 736 districts with almost over 16,000 primary health centers. So this tool gave a visibility to almost all of the states and all the hospitals. Now came the Delta variant, so which was again pretty challenging. Again, this was not about PPE kits. This was all about concentrators. This was all about life-saving oxygen, cylinders. So now we were talking about a setup where states and center can talk. Now we had one more player. So we had Air Force to talk. So Air Force, Indian Air Force would like to take the product to the last mile, to the most remotest location in India. So there, again, we stepped in. We extended our technology, we gave visibility to them, and we created something with almost 100 plus countries where they were donating, they were helping India. So this is like truly global collaboration, I would say. So this visibility was plug in and plug play. So the moment you have visibility and accessibility to such a tool, that supply chain became easy. And now while you're talking about the Omicron and thankfully the numbers are going down. So we have given a tool and we have created and modified by creating a buffer capacity. That means we are war ready. So anywhere across India, basis on our analytics, basis on our data, we created minimum stock levels. So if any such contingency comes in any state of India, we can immediately plug in, we can just move in, and like the war-like situation, we can just go to the last mile. And we can, so the beneficiaries would have to wait. We don't have to create an infrastructure for cold supply chain. We don't have to create infrastructure for the last mile delivery. So this was all done, taken care of. And this can be scalable anywhere because this is a plug and play model. So if it works in India, I think it will definitely work for Africa as well. And we would love to share the case studies. We would love to share our practices. And as Dr. Akwale has also mentioned, the consumables form a huge part of the vaccine project, because for every one pallet of vaccine, we are looking at around 25 to 30 pallets of non-vaccine stuff. So I would say that the tool is all ready. We are very keen to collaborate. We are definitely looking forward to share the knowledge and the learnings which we had over the last 2 years. So it'll be our pleasure to that we are part of such a summit. And Mr. Gautam, I think I would definitely want that if any sort of a question or any clarifications if sought by anyone in the panel or the participants, I would love to clarify and would love to answer all those.
Sure, thanks. Thanks, Rahul. So we don't have any questions in the Q&A as of yet. So maybe as we proceed, we will expect some of the questions. But I really congratulate you on this edifice, the platform that you have created, which not only looks at the logistics, but also is adaptable enough, like moving from PPE to maybe oxygen and something else that is needed. And I believe like the partnership that we already have between USAID, IP Global, the Samrit, the blended facility, and you. So with now, let's see, with partners in Africa, maybe we'll find some ways to solve some of the problems there also. So at this point, let me move over to another panelist, Dr. Eva. So Dr. Eva, you're not only the chair of Medical Practitioners and Dentists Council in Kenya, but also on the advisory board of Diabetes Africa, and has been looking at various alliances for research and other work in this pandemic. So would really love to hear from you what your experience had been in this pandemic, how you have brought together various parties to tackle this issue, and what role the government and private sector had played and you would like them to play going forward. Over to you, Dr. Eva.
Thank you. Thank you, Chair. His Excellency, the High Commissioner, India High Commissioner to Kenya, the organizers of this very great and apt meeting, my fellow panelists, the attendees, all protocols observed. I would really like to appreciate the organizers and appreciate your putting us together to discuss a topic that's live in every person's mind who has had to deal with this pandemic. When the pandemic hit us in March 2020, I, being in the council and being the chair of the regulator of health delivery in this country, we were tasked by the minister and the minister hierarchy to set up a quarantine and isolation command center. I can tell you it was confusion from day one because we really didn't know what we were fighting, what we were up against. But I can tell you with the leadership from the Ministry of Health, with the leadership from the government that set up a high-powered committee and task force to guide everybody on the protocols, we started somewhere. We had challenges, we learned from those challenges. And I can say without doubt that Kenya has done quite well. With all the challenges and with all the difficulties, I know we have done well in containing this pandemic. And we will continue to learn from those who have also done well in other globally in other countries. And we are learning now, and I'm listening to all the presenters, and especially the so experienced colleagues from India and those in manufacturing of vaccines, those in delivery of and distribution of vaccines. I'm just realizing that if we collaborate and work together, not only are we going to be able to contain this pandemic, but other pandemics, because this is not the last pandemic. So we need to not stop here, but prime ourselves for any other pandemic that might come. So what I would like to start off by saying is that having been tasked by the minister to put up a committee to see how best, when we got to now to the vaccines being delivered, we realized, and we all know, and India, of course, was very helpful to us, gave us, I think, our first batches of the COVID shield. And we still are grateful to the other Western countries that gave us donations. We started small, but we need, and we keep on saying and advocating that until all of us vaccinated, until all the people who are at risk are vaccinated, there's nobody who is safe. So there's no way that we can all sit back and say, now that India has reached 1 billion, if parts of the world has not reached even 1 million, we're still at high risk. And Omicron has showed us that. It came and hit the world as if nobody had been vaccinated. So we set up a committee of private partners, the government, the stakeholders in health. That included associations that take care of the health workers, both doctors, clinical officers, nurses, pharmacists, all the people that are really have been tasked to take care of people's health. And because Kenya has a devolved government, we also, this committee had the representation from the Council of Governors, because we did realize that it doesn't matter, the national government couldn't do this alone. The people where we need to deliver these vaccines have their own local council governments. So we started meeting regularly every week and exchanged ideas. And you immediately realize the strength in collaboration and sharing, how you can attack and deal with problem when everybody is on board. And even if the vaccines so far have just been under the care of the government of Kenya, there's no way the government would have done the rollout on its own without all these other partners. And I thank our government, the people in the ministry. Dr. Willis can tell you how we have worked. He was part of that committee. And the input from the private sector was amazing, because they came out and have helped in certain and several ways to help the few vaccine doses to get to that last mile. Because we talk about vaccine hesitancy. In most of our parts of the country, it's not hesitancy, it is lack of vaccine. So you cannot keep on saying that people are not vaccinated because they are refusing when they actually haven't had a chance to get the vaccine. So with the joint effort, this rollout and what Dr. Willis talked about, mass vaccination, the drive, we have seen the uptake going quite high. Then we have also seen that creating awareness and getting people to know the facts about the COVID, about other measures that strengthen your immunity, because vaccine alone will not work if we don't observe all the other protocols. This has really come through from our stakeholders, our medical associations, the nursing associations, the clinical officers associations, the county governments, going out there, going live to the social media, going to the usual standard media to talk about the benefits and the safety, and tell people also about adverse events, because there's no treatment, there's no medication that usually doesn't have some form of adverse effects. But when you empower people to know this, then they make informed choices. And we've realized this has helped. Going to the churches bought in and had their buy-in, and they supported and talked to the congregation, talking to the local administrators and getting that information out there. It really has helped. And this is one of the things I can say from experience. And we continue to work as a team, as partners from all over the various stakeholders to make sure that this information continues. And of course, Willis talked about now the system that we are using, the Charger app, and how people now can very easily access it and get vaccinated. So I think there's a lot to learn from each other. And as you said, there's no need of reinventing the wheel. ED has succeeded. You've manufactured your own vaccine, the AstraZeneca. I think it is high time Africa also started their own manufacturing, not just of the COVID vaccine, but other vaccines and other medicines. And I am happy to know that a good number of African countries have ratified and signed the treaty for the African Medicine Agency, which is going to at least oversee quality medicine manufacturing in Africa. And when this is done across the board and across the continent, especially in Africa, we are going to help each other so that we know we can have the movement of the medicines across. We don't have Kenya, Uganda, Tanzania, especially our East African community that works quite closely, whereby even as regulators, we have a body that work together to make sure that our trained professionals really are being trained in the same way. It is easy when we come now to manufacturing that we can share ideas. We can have the private sector bringing in their resources in a various way in technology. And as Dr. Akware said, the support, that support, and all of us knowing that this is for our people, this is for us to keep our people safe and healthy. So I think the kind of collaboration now between private and public sector has shown that it bears fruits, and in every way that we must continue and uphold it and support it. So I think this is one meeting that I'm finding that moving forward, our Indian colleagues have said they will share their case studies. So Dr. Akware and other African leaders and partners in this meeting, we do not have to start from zero. It will be almost an accelerated and escalated process. So I think this is really the way to go. And I thank you all for this. Over to you, Chair. Thank you.
Thank you, Dr. Eva. And I think the two most important thing that you really mentioned, one was these governance structures that you talked about, like when the public and private sector has to work together at the national level, sub-national level, people have to come together and keep the dialogue on, so that whatever issues are coming up, that can be solved then and there, and people can be benefited. And the other very important point that you really mentioned about is the manufacturing locally, which would definitely involve, say, cross-border sharing of technology, sharing of capital, investments, and all that. So I think going forward, we really look forward to these kind of things. And as partners, wherever we can collaborate, we really look forward to that. So at this point, let me bring in Mr. Samit Jain, who has a solution on the cold chain supplies of vaccines. And again, we had been collaborating on that. So Mr. Jain, would you like to really talk about this particular solution, how you have scaled up, and what kind of support within India and also going globally, if we look at the African market, how do you really see this shaping up and whatever plans are going forward? Over to you, Mr. Samit Jain.
Thank you, Gautam, and thank you everyone for this opportunity. I think several speakers in the last 1.5 to 2 hours have elaborated that how India really moved forward in this past 2 years to find solutions for whether it was manufacturing vaccines or whether it is transporting, logistics, software, handling the entire supply chain. So it's been a great learning for India, and I think it has been a great learning for all of us that if the government, the private sector, and multilateral agencies like USAID, if they work in tandem, a lot can be done, and it's actually demonstrated that. To give you a good example, we as a company played a role in all the 3 phases. Let's say the diagnostics, the cure for the disease or the COVID, as well as for the vaccines. And all of these were great instances where there was a partnership between different companies as well in the private or the public or even the government. For example, the Tata MD, Tata Medical Diagnostics, made the CRISPR kit for testing. This was actually a technology that ICMR, or one of the, not ICMR, but one of the CSIR labs in India, the IGIB, had developed. And Tata Medical and Diagnostics took it over immediately and upscaled it. They approached us, and within 2 months, we manufactured a box that could maintain minus 20 degrees for transporting this kit, because some of the reagents had to be at minus 228 and some at minus 20. So we made a solution. So it was a combination of Tata Medical Devices, us, as well as IGIB, which got this out and rolling. Another example to take is, for example, the Sputnik vaccine, when it came into India. It was not used much, because by then AstraZeneca and Covaxin had kind of scaled up pretty well. But whatever Sputnik was transported needed a minus 20 degree solution once again. And for Dr. Reddy's, that was done within a span of 2 months. And the programs like Samrid and USAID, which gave us funding to scale it up and supply to Dr. Reddy's within a span of 2 months, in the months of June and July, when a lot of these were imported into the country and then distributed, happened because USAID or Samrid came up at the right time to enable smaller organizations with the money and who could scale it up and take it forward. So such kind of associations between different partners with different strengths have really helped India create all these solutions. And as Dr. Eva mentioned, it's no point Africa trying to reinvent the wheel. The solutions exist now, and these can be taken forward and adapted to suit African conditions. So it's important that all of us use these learnings and work collaboratively, because as I think Dr. Willis mentioned, the virus knows no borders, and we've all seen it. I mean, Omicron started in South Africa and is all over the world today. Europe and US are the worst affected. So we have to share this knowledge, and I think the African government today should also be more receptive in terms of creating such opportunities for private companies from India to come forward and help them set up solutions, rather than just importing using grants which may be available from various multilateral agencies, WHO, USAID, ADB, etc. So the funding should now go towards creating the capacity locally within the 40 odd countries that form Africa. So, and I believe that Uganda has already started doing such things. There is land available. The government can pitch in by creating easier policies, lesser bureaucracy, and subsidized land, electricity, etc. And the private companies would be willing to, because today the developing countries are the ones which really have to help each other, and not just depend on developed economies which have other very often other agendas in mind, just to take their technology forward. But a lot of these technologies can be much more economical, and we have seen it. I mean, vaccines in India were 200 rupees and vaccines in the US were beyond $20-40. So there is a cost arbitrage benefit that we have, and countries like India and Africa can do it together. So I think it's been a great journey creating different solutions. Even for diagnostics, we went ahead and did it for Tata MG, Dr. Lal Path Labs, Helgians, to collect the samples at the right temperature. So all these solutions for the temperature control, which was never looked into or never taken seriously, are today there, which work in a tropical country with temperatures ranging from, in India, as low as -5 or -10 in Jammu and Kashmir, to as high as 43 degrees in, let's say, Delhi or Rajasthan. So the whole range of solutions are today available, and they all apply to Africa. So I think it's an opportunity where the two governments and the companies can come together and leverage everything that is learned for the future pandemic, and not just pandemics, but the regular immunization which countries like Africa today, in Africa today need. for children, for others, adults. So I think that's about it from my side, Gautam.
Thank you, Mr. Jain. So I think the last part that you mentioned about not only focus on the COVID vaccination, but to use for other things. We also heard from others, especially the NHA CEO when he was speaking about the app being used for routine immunization and others. Also, a very important point that you mentioned about is this collaborative work. So the government, private parties coming together and working together to look at what is needed, either at the policy level, investment level, market reach out, and also the important part that you mentioned about USAID with that funding coming in, which actually highlights the role that even innovative financing options like blended finance that we have, which includes investments as well as grants and all, coming together to really see if we can scale up the solutions that you talked about. So in this slide, let me bring in the next speaker, Ms. Carol. Ms. Carol, you have played a really transformative role with the Kenya Private Sector Alliance and has been looking at how this a little back, maybe a little known business institution is now really influential in Kenya and globally. So would really love to hear from you. What are your perspectives on this partnership that Mr. Sameja and others had been talking about? How the public and private can come together to work on manufacturing, supply chain, other issues that various speakers have talked about. So over to you, Ms. Carol.
Thank you very much, and good afternoon or good evening, depending on the time differences. And thank you, Your Excellency, and the panelists and all the participants. I'm really grateful to join this panel and just listening to the different ones. It's really a learning experience, but also sharing best practices. And I think for me, this is the exciting moment that we're able to sit back and look back, because when you're in the trenches of work, you don't feel like you're doing enough until you start listening to what everyone has been doing and you realize we've done something. And so I'm really grateful. And as you said, yes, KEPSA, we're an intermediary organization, and we bring the private sector together in Kenya in one umbrella, and then work very closely with government on policies and implementation of those policies and different programs and projects. And we also work with other partners, development partners and civil society and everyone else as much as possible. And so this is one of those the pandemic was one of those that really tested that strength of the partnership. And I think we really must say that we look back and realize that the partnerships that we have developed over time, especially with government, were really important and key. And just touching on what Dr. Eva Jenga said about when the pandemic began, and we're all scrambling to look, when we're talking about lockdowns, we're talking about how do we separate people who are positive from those who are not positive and all that. And it was hard. And I think for business, we had to really think very creatively, how do we work with government in this agenda? And that has really been impressive. And I'll just share on a few things that as I look back, and even as now we go forward and start thinking, how do we prepare well for a pandemic? How do we go into the supply chains and the manufacturing? And one of the things was immediately we talked about quarantine. I know it was difficult, and government said, well, we have these facilities. And we said as private sector, how can we support that? And you did offer some of our hotels, and Dr. Theka can remember that, how we used to have very late conversations and meetings with our hotel sector and saying, who are willing to be involved in this? How do we work with the hotels? How do we work with the airlines so that we are aware which flights is arriving? And there was a lot of confusion, but it settled after some time, and the processes started working better. We started working with the travel agents and all that. Just how do we move people from the airports? How do we move them to quarantine centers? Which are the hotels, and how do this government support some of those hotels that were willing to do that? And so it was a hard task, but I think by the time that settled, and we stopped having it as a crisis as we went along. Then of course we worked again very closely with government in looking at the tax issues and what else could we do, to really cushion business in the crisis. And we did work on the whole issue of VAT. How do we work on the other taxes, corporate taxes and all that? And we did, and government was very, very kind to listen to some of our proposals and adopt that, and that cushioned business business. So while we were looking at businesses around the world and the struggles businesses were having, and going back to government for subsidies, I think we did well, as a developing country without and government not having endless resources and looking for resources at that point. They did well to really look at some of the taxes that could really help, especially the very vulnerable. But also business did stand up and really just move to another level and say, what can we do despite what government is able to do? And started a lot of projects, a lot of programs to cushion businesses, to cushion the small businesses. We did a lot, and I don't want to get into a lot of those details on how we supported the SMEs in terms of with free loans, interest-free loans for the small enterprises, getting our SMEs to really digitize so that they could be able to be able to do business online, because there was lockdown, not only in Kenya, but also in other parts.
I think we have lost Carol.
Yeah, I think we can't hear the sound. Could be a signal issue. But Gautam, I think she was also talking about the financial overarching support for SMEs.
Exactly. Yeah. So that was actually quite important. So
and providing funding on how they actually managed to deal with the fight. And under Kenya Private Sector Alliance, there is a specific program on helping small and medium enterprises. I'm sure Carol can add more into model, but I think the drift of that was capital has quite often been also a barrier in this process.
Sure.
Solutions. So Gautam, maybe you can take over in
maybe we can move on, because I think,
and of course from there, if Carol comes back, she can end the last part of her intervention. Gautam, back to you.
Sure, let's see, because anyway, I think we are almost like 5 or 10 minutes over time, and I really don't see any further Q&A here. But I think this is a very important point that Ms. Carol was talking about, the access to capital.
I think she's back.
Sorry, I'm back. I'm back. Sorry, I lost power, so I was trying to connect on a different one.
Please carry on. I think you were talking about
my apologies.
The access to capital.
Yeah, so we did the access to capital. We started looking at that, and then we the other area that worked very closely with government, and I was part of reopening the economy. And we said, if the economy is going to reopen, and we are still in the middle of the pandemic, what can we do? We worked on the health protocols for business, and that's for all the different sectors, and said these are the sectors that are first hardly hit, the hospitality. So that was the first sector that we worked on the health protocols, and worked very closely with our health sector, the private sector to just advise us on some of the areas that would be important. How do we put the sanitation places at the entrances of different businesses and all that? And that really helped. So government was able to start reopening the economy and reopening one sector after another and a few sectors at a time until we finally reopened the whole economy. So that was the second thing about us working closely with government. Then the issue of, then finally we got, so that, and then the testing area, because government hospitals were the only ones first mandated to do the testing of COVID. Then we said we can complement government. We've always worked very closely with government to complement government's efforts, because government cannot do it all. And so we were able to work with our private sector institutions and hospitals to say, what do you need? And so that you can have the testing equipment you need, and then you'll be approved by government. And so that happened. And so that made it much easier, much accessible. And it's just amazing for those who are in this conversation, when you travel to other parts of the world, Europe and the US, the ones that you think are more sophisticated, and how hard it is to get your test and get your results easily, especially if you're traveling and doing turnaround travel. But that's become so much easier in Kenya. I didn't realize how far we had moved in that compared to some of the countries that we were looking up to and working with. And so that, and up to today, it's so much easier to get your test and get your results and be able to travel, or at least be able to test your employees and know what's happening in your company. So much easier than waiting 2-3 days. Now within 6 hours, at maximum 24 hours, you can turn in your test results, and even faster. than that. So that was the other one. So I've cut a lot, but I just wanted to pick the big chunks. Then the last one came with the vaccines. So then vaccines, you remember with the whole issue of the global vaccine shortage, and Kenya wasn't lost on that. So we had shortages of vaccine, but the government really worked hard to really see how they could bring vaccines. And in the middle of that, we said, you know, again, we've worked on all the different areas, including fundraising for different initiatives, for PPEs. We're able to turn a lot of our manufacturing companies to producing PPEs so that finally they were available, and they were available at a friendly cost to consumers, to hospitals and all that. Now we need to move to the area of vaccines. And so we approached government again, and Dr. Akwale was very involved in this conversation, and we said, you know, we can help out. I know you have made a lot of your orders out there, but one of the challenges that we know is not just that there is vaccine hesitancy, it's also the access to the vaccines. You know, people don't want to go to hospitals, and I don't know how, I may have missed some conversation, how India dealt with that. You know, people are not going even for other diseases to hospitals because people are afraid of catching vaccines. And so we said, how do we partner with government to get some of those vaccines and be able to get them closer to the people? And we can take a chunk of where we are able to, and start with the private sector and the communities around us. And so that's what we did. And we went in and we said, let's begin small and continue to, as the vaccines are available. And at that point, we could get at least 200,000 vaccines. And we went to our companies and we said, let's work with the J&J because it's one shot, so we don't have to look for people again. And of course, the logistics, because of the logistics part of it. And then of course, the hospitals and the private hospitals, we asked them who would volunteer to be part of this. And so companies did put money together. Again, we sent an MOU with government on that. And we're trying to achieve three things. One, as vaccines come and government is putting their money, we can quickly put some money forward and be able to pay for some of the vaccines that are available as they come. So that was one. Secondly was communication, so that we can help with dealing with the myths around vaccination. And it's easier when, as a CEO, I sit with my employees and I tell them, we're going to have a vaccination drive tomorrow, and have them ask all the questions about vaccines. And then that's easier because there are people are reading from Google and everywhere else, and they were not asking those questions in public. And so there was hesitancy also because of misinformation. And so when you bring the vaccines to close and to the companies and to the employees and their families, then you can have those discussions. That was the second thing. The third thing was actually bringing the vaccines close to the people. As I said, people didn't want to go to the hospitals, and there's you know, and the distances and all that. So bringing them to the workplaces, that meant the vaccines were available and they were right there. But the fourth thing was also getting to especially the small enterprises, the traders and all that. And that's what we had started doing towards the end of last year. And we're going to continue to do that as we continue to work with government, even though the companies now could be able to pay for the employees and their families and for the communities around those companies. What about the traders? And even for the traders, they don't want to leave and go somewhere else in a building, you know, so how do we get them to the markets? And so we started working with the markets, and we worked with 2 markets now in Nairobi, and we hope to continue to work on the other. And then a lot of the focus we're doing right now that we want we're engaging government to work with is the messaging, so that we continue to push the messaging out there, and so having a communication plan. So we've developed a really elaborate communication plan that we want to be able to support what government is doing, so that we continue with the vaccination exercise. I know when government also said, okay, we're going to have some rules around accessing government services towards the end of last year. If you're not vaccinated, we came on board and said, we're also going to do the same. And a lot of our big hotels did adopt that, and some of our big supermarkets did adopt that. And that was just again to increase. But we said, as we do that, how do we keep making sure that the vaccines are close to the people, so that we are not actually punishing the people? And at first there was hesitancy, especially the hotels, because they said, oh, we're going to lose all our bookings, especially international bookings. But when we looked back at the holidays in December, no one lost business, you know. So it was just a fear of what that could be to the travelers and all that, but no one lost business. And so it's not an issue anymore. So there's no vaccine mandate right now as much, but at least we're trying to continue to do the communication. We're still keeping a lot of our health protocols, washing of hands, checking temperatures, just simple things that that are also helping with other infections, health infections that people contact because of just cleanliness and all that. So that's helping, and that's still being done in most of the premises. Going into vaccine and then the supply chains, of course, we did offer. We said if government isn't when we're taking the vaccines around the country, we used a lot of where the hospitals that we were working with could not didn't have the means to take the vaccines to the places we did support that with transport. And we do offer, we've also offered the logistics and the cold chains wherever government is in need that would be able to support in that. And so we'll continue to do that. Then as I finish up, and I'll allow for questions because I've left a lot out, is the vaccine manufacturing and all that. So we are involved in those conversations. I know, I'm sure Dr. Akwale must have mentioned about what government is doing on the manufacturing. I think just yesterday I did see on CNN, I think Senegal has already gone ahead and has opened their facility. I know something has been, and then of course there's been South Africa and others, but we want to be able to do that. And not only just have one. Our intention as private sector is to say, how do we manufacture both medicine that are needed for most of the common diseases that we are seeing with the public, but also in the society, but also the vaccines, and not just COVID vaccines. How can we be a manufacturing hub, especially for this region, for all the other diseases? And so those are the conversations we've been having, and a lot of work has gone into that. And I'm sure in the next couple of years, I think we'll have gone into that and working very closely with like India, which has gone ahead in some of those areas. Thank you.
Thank you, Ms. Carol. And with the fantastic work that you have done, I believe most of the participants on the panel today and also others would really look forward to your leadership and engaging your organization as we move forward to tackle this global pandemic. So we, I see, are already almost like 15 minutes over time. So we really don't have time for Q&A, but let me come back to the chair, Mr. Sanjeev Navangul, for your closing remarks, please.
You're right, Gautam. I think we are much over time, so let me make it very short. Look, all the panelists were excellent. I think they gave real life experiences and told us what is really the challenges that they faced and how they overcome them. It was all about three things: innovation, sharing of experiences, and openness to collaborate, because this was a challenge to humanity. So these are the three things that they, in a nutshell, shared, which is very important for us to be prepared for the future. And let me end by saying a local saying that which says, Ekameka sahaya karu avgedaru supan, means if we want to be on the right road, we have no choice but to help each other and support each other. So let's stop here. This has been a very engaging session, and we should respect time. Thank you.
Thank you, Mr. Sanjeev. Over to you, Julia.
Thank you so much. Thank you, Mr. Sanjeev, Mr. Gautam, and the panelists. This was a stimulating discussion with a number of key takeaways. With this, we are about to bring this summit to a closure. I would like to now request Mr. Siddharth Bhattacharya, Secretary General, Nat Health, to come on screen for concluding remarks and vote of thanks.
Good afternoon and good evening, everyone. In the interest of time, I'll be very brief. About little over a year back, Nat Health and African Healthcare Federation had come together and identified 4 strategic themes. They were medical value travel, medical education, skill building, supply chain strengthening, as well as improving service delivery, particularly through technology enablement, research, and data analytics. I'm very pleased today that in the last 18 months, we had broadly 3 key objectives of this partnership. And Amit is right here when we had the conversation the first time. The first was to get engage into a strategic dialogue, get the ecosystem on both sides, the decision makers, industry, get the core industry certainly but certainly get a much larger periphery outside the industry to talk about opportunity areas and bi-directional opportunity areas. Second objective was to galvanize action. And I think today's discussion has outlined a number of opportunities which our technical and knowledge partner IP Global will summarize. And we will pursue this to see if there are a couple of these opportunities that can be enacted upon, and hopefully they result into the third pillar, which is tangible results and outcome and impact on both sides. So with that spirit, I would like to thank the speakers. There has been a series of outstanding speakers. I'd like to thank Dr. Leah Tedesi, Honorable Minister of Health for Ethiopia, and Dr. Aresh Sharma for the session around technology-led innovations for scaling of vaccine delivery and managing a transparent backbone for overcoming this pandemic-related challenges. The stage was very well set by Dr. Virender Paul, the High Commissioner, His Excellency Dr. Virender Paul, the High Commissioner of India for Kenya, where we talked about many, many milestones on both sides and the opportunities to do many more. The conversation by Mr. C.K. Mishra and well followed up by Ms. Anjali Kaur from the Deputy Assistant Administrator from USAID, it focused a lot on really efficient vaccine delivery by strengthening supply chain and countering the hesitancy. And I think the last session, very, very remarkable in terms of bringing the voices of this entire community, private sector, government, not-for-profit sector, weaving into donors and the multilateral stakeholders is a very effective pathway for us to take this dialogue forward. My job will not be complete unless I acknowledge a few individuals and teams that have worked tirelessly to bring this, to build this program. On the African Healthcare Federation side, I'd like to thank Dr. Amit Thakkar and his team, Lauren Fernandez, the IT team led by Mr. Bildad, Collins, Joel, Manli. From the IP Global team, I'd like to thank Mr. Ashwajit Singh, Mr. Himanshu Sikka, Ms. Deepika Joshi. On the communication side, I'd like to thank Julia Joseph, Samiksha Thakkar, Ms. Gulshin. Also on the NatHealth side, Ms. Anugrah William, Anesha Pandey, and Brinda Chaturvedi. I would like to take the opportunity to thank the leadership team of NatHealth, both Dr. Harsh Mahajan and Mr. Amit Thakkar, and Mr. Sunil Thakur, who moderated the digital side of the conversation. Last but not the least, very importantly, we had an eminent set of audience. Many of them are innovators, many of them are banking professionals, very rich experience, and they've left very valuable comments in the chat boxes. For the interest of time, we didn't have a lot of time to pick up those questions, but our team will ensure that we document them in our follow-up report. Those are addressed and incorporated. But I would like to thank each and everyone who has been a patient listener to this summit. And hopefully by the time we meet again, we would have translated many of your ideas into real practice. With those words, I would like to hand it. I would like to thank one other individual, of course, Mr. Sanjeev Navangul, as well as Mr. Gautam Chakravarti, who have weaved in the theme of the private sector, the multi-stakeholder collaborators, and the government participants very, very nicely in their discussion for collaboration for impact. With those words, I'd like to thank everyone and hand the mic back to Julia, who will conclude the session. Thank you, Julia, again.
Thank you so much, Siddhartha. Once again, thank you for joining us today and making this summit a resounding success, and wishing you all a safe weekend ahead. Thank you, everyone.
Thank you, everyone. Wonderful
Thank
work.
you.
Thank you, everyone. Bye-bye.
Thank you.
NatHealth. Bye. Bye.
Hi, thank you. Thank you.